So there's my disclosures. Basically, I'm sponsored by everybody to come and teach. And also I'm a trustee for the anaphylaxis campaign as well. So a bit about myself. Primarily, I'm still a GP. And essentially, because my eldest son, Ethan, who's 13 now, had milk and nut allergies, I just realised how little I knew and how many terrible mistakes I made in his care. And eventually, when I popped along to his clinic appointment to see his consultant and relayed how he had anaphylaxis that I hadn't recognised, his consultant was like, I think you should do some further training. So in true me style, when I was really heavily pregnant with my third, I did the Masters in Southampton and loved it. And it is really useful because I've then went on and worked with the paediatric allergy team at Southampton. So I've worked in primary care, which I still do, secondary care, tertiary care, and got personal experience of what it's like to manage allergies and live with it. And for me, I was probably one of those more blasé mums, but it's been interesting to see how actually my son still had anxiety. So even though I was quite chilled, he really wasn't. So families find it quite useful. So when they come to me with all their guilt, which they do, I usually reassure them that I've done much worse and I'm a doctor. So I've got a private clinic now just because of the challenges of trying to get commissioned as a GP to work in a specialist service, which is a bit of a shame. And primarily, I still do my GP work. And I was the primary care chair for the British Society of Allergy for the primary care group, which is really useful. And sometimes I see those 5 kids that we have, but, you know. So I've been asked to talk a bit about the challenges that we face in primary and secondary care and a little bit about collaboration, and then also talk about IgE allergy and non-IgE allergy, and then particularly thinking about the management of non-IgE mediated allergy for formula-fed infants, and then Lisa will do the breastfed ones. So basically, there's always reports that keep coming out saying allergy, the unmet need, and how we're essentially failing our patients. And if you look time and time again, the reports still say exactly the same thing in that, you know, allergy is increasing and we don't have enough services available for them and that we need more specialists. And the National Allergy Strategy Group in 2014 still highlighted that. And then they talk about how we need more specialists, how we need more education in primary care, and yet that still doesn't happen. And it is shocking when you think, you know, sort of 5% of children will have food allergies, a third of people will have rhinitis and asthma and all the stuff that we're expected to manage in primary care. And then I also think it's always just worth bearing in mind that not only in primary care are we asked to manage all of those that have A to P and food allergy, but also we're going to be seeing all the ones who think that they've got food allergy, and that is a much higher proportion. And yet, sadly, until a couple of years ago, allergy wasn't even on the GP curriculum. So it has now changed, but that's going to take time to filter through. So I forever at conferences hearing like specialists say, why don't GPs know this stuff? And it's like, well, you know, the education is pretty poor. And actually, if you look to secondary care, often general peds don't know this stuff. Emergency departments don't know this stuff. And I do think that their GPs are being asked to manage quite complex bits of allergy. So IgE allergy is arguably quite straightforward. And yet we're asked to manage the non-IgE allergy, which I think is much more complex than specialists give themselves credit for. So really what's essentially happening, like everything in medicine, is that we don't have enough specialists. There isn't enough funding for that to happen. So what happens? Everybody says, well, let's give it back to primary care. They can manage all of this stuff. And that's not happening, and that means our patients are having a disservice, really. You can see all my woes of being a primary care doctor. I've been a doctor for 16 years and a GP for about 10, I think, including training, and it has really massively changed. So gone are those days when we'd have really long lunch breaks and, you know, my colleagues would pop off to the golf course. Now you are scrabbling for any bit of time, seeing longer and longer. I think average patient contacts in a day is about 60. And if you think about the reality of that, 60 with all their referrals that they want and blood tests that they want and analysing all the admin. And then I can't tell you the number of times now that we get letters back from secondary care saying, please, could the GP just do this. And you might think as you're one person in secondary care, that's not a big deal, but it just adds massively. And then we get things like, you know, you guys in secondary care, if there are any of you, are also under pressure to discharge everybody really quickly. And then there's no time for discharge summaries. So I come out and I'm like, I haven't got a clue what went on in hospital. And people then get bounced back and forth really quickly. And the NHS really is in a bit of a terrible state. It is quite sad, but we're all still in it because we're really passionate about providing care. But actually, it's really bloody hard at the moment. It really is. And then obviously GPs, we're responsible for delivering the bulk of the COVID vaccinations. We can't get staff either because who wants to do it? I'm a locum, so I've got a regular locum job, but they keep saying, will you be a partner? And I'm like, no, why would I? I get paid more being a locum, less responsibility, not going to do it. And then if you add in the milk allergy side of it, it's really hard in primary care. And this is where I sort of really want you to think about the non-IgE stuff. So recently I've been trying to work on some private stuff. So I've been looking at the Facebook groups that exist for milk allergy. And they've got thousands and thousands and thousands of members in there. And so first of all, people keep giving themselves absolutely terrible advice in there. You know, anaphylaxis last night, especially the Americans, you know, like I'm Anna to peanut. And just give it if you get hives. And I'm like, no. And then one last night said, I've been, you know, an hour and a half since I've given my EpiPen. When will I feel better? And I'm like, why aren't you in A&E? Like, and milk allergy, like, you know, I've been given an extensively hydrolyzed formula. I wanted Neocate. It's always the way. They always want Neocate for some reason. And then other people saying, just pretend that you've tried it. And I'm like biting my tongue in these groups. And that is the reality of what you're facing. So people are coming to us with this massive overload of what they've learned on the internet, being told things that maybe apply to one person's child and not another. And then they're coming to see non-specialists. I won't say like me because I have got experience. And being expected to understand, you know, these patients are really hard. These families are really hard to manage with a non-IgE allergy. They have their own agenda. They know what they want. We've got probably slightly basic grounding in allergy, so not enough confidence to explain why that's not necessarily the right thing. And obviously the diagnosis of milk allergy overlays with loads of other things, you know, mainly all the dysfunctional gut disorders that children get better from. But so it is really hard. So I just ask you to empathise with, and this is one teeny bit we get asked to deal with, let alone everything else that's being pushed back to primary care at the moment. But just to mention my secondary care colleagues too, it's also really tough in secondary care. You know, I work in a hospital centre doing GP stuff. You pop into A&E at the moment and it is just ridiculous. So I was like, I've got this really septic young man here. And they're like, yeah. And I'm like, well, you know, are you going to get him in recess? And they're like, oh, those 1 hour timeframes are out the window. And I'm like, oh, God, like he was really ill. And that's the reality. You are also not able to do the job that you want to do because far too much demand, not enough staff, COVID causing a nightmare. You know, allergy itself, if you just think about allergy, is on the increase. It's really tricky. Then you have things that just don't make sense. So your systems don't communicate with our systems. You can't order prescriptions for people in the community because they've got to come back to hospitals to collect it. You know, you've got to follow up bloods. It makes no sense. The whole thing is ridiculous that we don't work together, really, in my opinion. And also, like, try calling a GP. It's just a nightmare, isn't it? You can't get hold of us. So I do feel sorry for you too. So if we work together, we will ultimately make better care. We'll have more appropriate referrals, and we'll learn more about tolerance. We all like to think we're tolerant of each other, but the reality is we're not, you know, unless it's your friend that's the cardiologist or your friend that's the GP, you're a bit tolerant of them, but actually you can still hear the language that is being spoken about as you come through junior doctors from both GPs and secondary care, in that we are frustrated with each other, when really what we're actually frustrated with is the system. And if we work together, then we'll learn from each other, and then we'll upskill, and that is the only way I believe that it will upskill, and ultimately the patient would benefit. This is a literature review where they looked at trying to identify what themes we needed for collaborative working. And you can essentially see that we both say the same thing about each other. So specialists criticise GPs for not understanding them, and GPs criticise specialists for not understanding us. And I do think it's often overlooked that we often know our patients really well because we've known them for a long time, particularly if you think of GP in a traditional sense. And it always amazed me when I worked in hospital and then went to be a GP, that people would come to me and say, the hospital doctor said, do this. What do you think I should do? They never followed a hospital advice until they'd come to speak to their GP. And that's just worth, you know, bearing in mind. Plus I only do home visits, so we'll have a sense of what's going on in that house. But I really like the last statement, which was better cooperation is likely to be accompanied by a change in attitude, and stop talking about my patient or your patient and our patient. And none of us do that, do they? We don't ring the consultant or the GP and say our patient. We talk about mine. And I think if we change our attitude, it will change things. And this was a study that just showed there are different thoughts about working in the community. Some people will come and work in a community clinic where they're based in the community, thinking that maybe then if GPs have got access to them, it will upskill the GPs. But the reality is we all sit in our own rooms, and that didn't show to upskill GPs. But what was more likely is if you did these joint consultations where essentially you're all on the same Zoom call, GP, consultant, and the patient. And that does work better in today's society where we all are more used to working online. You just have to be very clear about who's responsible for what, who's writing the clinic letter, who's going to follow up with what. But it was essentially shown that that was a much higher satisfaction rate. But of course, sometimes the patients found that they felt a little bit nervous about it. But as people get more used to these things, it could work quite well, I think. So just thinking about how can we improve, I think joint clinics is definitely a potential way forward. diabetic clinics have done that for quite a long time, where the specialist diabetic nurse would come and work with the specialist nurse in our clinic to look after challenging patients, and you do see an improvement then in what's going on, because that repetitive contact with the specialist helps you learn. You know, I can tell you today, I'll give you all this information in a minute, and you'll go, you won't remember it, but you need it again and again and again from me. So I also think there's a role for more regular access. So I have in the Dorset area a Facebook group that's closed, which GPs are on, so they can come on and ask me questions. You know, there's a physician's mums one where there's thousands of members and they all ask each other questions, and it's closed, and the BMJ do support that. So clear guidelines. I agree with you. What's the point in us all writing separate information sheets? So when I teach, I say, you know, this is what we do about may contain down south, but up north they do something completely different. We just all need to be saying the same thing, have it ideally in one place so that GPs know what the hell is going on. And then with the fact that as GPs we've joined these networks now and given the funding over to networks, so essentially where 4 surgeries get together and pool their funding, there is funding available to then put money out to do things like hire dietitians. And, you know, Lisa's done a really nice study showing that when you have dietitians in the community, you get better use of medications, better patient satisfaction, shorter waiting times, better care. But there aren't enough dietitians either that know enough stuff about milk. So it is really tricky, but we just need to be pulling on every resource available at the moment. God, right, okay, now I've got to try and teach you about allergies. So we'll look at 2 cases, really, to try and demonstrate it. So Ben is 6 months old and brought by his parents who were concerned about allergy. He was given porridge, which contained milk, for the first time yesterday, and within 10 minutes developed urticaria, so hives across his face, and mild swelling, which of course is angioedema around his eyes. He didn't have any treatment, but his symptoms got better in an hour, and he was otherwise systemically well on the day. He's exclusively breastfed, but like many, had a bottle of formula at birth. He's had some fruits and vegetables without any issue at the moment, and he has no other health problems. So there was a question there, but what do you think it is? We're in an allergy talk, so hopefully you'd recognise that sounds like an IgE-mediated allergy, and that is a really classic history for IgE-mediated allergy. And NICE have defined the different signs and symptoms that you will see with IgE and non-IgE allergy and separated it into the organ groups. So for IgE, if you look at the skin, it'd be hives, swelling, redness. If you look at the gut, you might get swelling in the mouth. They often describe an itch within the mouth. So my little son would forever say, like, oh, it tastes spicy. And I'd say, eat your dinner. And then he'd swell up and have hives, and it had milk in it. But that's quite common, so listen to your children. And immediate onset of vomiting and diarrhea. And then if you look at respiratory, it looks a bit like hay fever, so you get runny nose, congestion, itchy eyes, and possibly signs of anaphylaxis, so coughing, wheezing, breathlessness, circulation issues. The timing is crucial in IgE allergy, which makes it just incredibly easy to spot, in that it comes within minutes to an hour or 2 after eating the food and is completely gone within an hour or 2. So when you come to IgE allergy, it's very rare you need to keep a food diary, because every time you eat that food, you swell up, you get hives. You know, the symptoms can differ from time to time, but it happens every time you eat the milk or the egg or the peanut. So it's really very obvious with that history. And that's why I think this is something that GPs could manage easily if it's just an isolated IgE allergy. So when we see them in primary care, you obviously give them the diagnosis. There is information we should give them about food labelling, which is available on the patient website, so that's where I direct them to. And ideally give them an action plan. So if you go to BSACI, which is the British Society of Allergy and Clinical Immunology, and put in the search engine action plan, you'll find 4, 1 for EpiPen, 1 for Jex, 1 for Emerade, 1 for no adrenaline autoinjector. And they haven't got their apps in gear, I don't know why, and developed one for the adults, but the same is true of adults, so I print this off and give it to the adults as well. And you can see it's self-explanatory, right? What they're allergic to, their contact details. You sign it at the bottom, which means if you've prescribed adrenaline, they can take it on board the plane with them. It tells them what a mild to moderate reaction looks like, so essentially hive, swelling, vomit, and then you prescribe some antihistamine, and then it reminds them of the signs of anaphylaxis, what to do, and how to use their specific pen. So that would be the least that I would like to see GPs do. But adding that into you've already had to spend 20 minutes taking an allergy history is challenging. But we should bring them back, or ask the practice nurses to do it, or ask our specialist pharmacists to do it. But we do need to do it. So NICE say that we should refer anybody who's obviously had a severe reaction, so anaphylaxis. If you're multiply allergic, you are going to need some help with that from dietitians and input. I'll come back to the eczema. If there's parental suspicion without supporting evidence, that is important because we do want our children to eat foods if they can eat foods. And sometimes it's only when they start school and you get a parent coming in saying, I need a letter for school to say that little Johnny can't eat this stuff so that school will make him meals. And you're like, blimey, what does little Johnny eat? And that sometimes is the first time that they've presented to anybody. And sometimes, despite our best efforts in primary care to say, no, look, they're not allergic because this, they're still cutting food out. And that's when a specialist comes into use. If there's issues with growth, IgE or non-IgE allergy, you want to refer them on. And asthma is a risk factor for anaphylaxis. So if you have an IgE allergy with asthma, then they should all be referred. The eczema, I'm in the camp of, if you've got a young baby with difficult to control eczema and you're looking at weaning or they haven't got food in, then they should be referred because they have got a higher risk of allergies developing. Or if you've got a person too paranoid about giving their child food or desperate to see an allergist because they're convinced it's linked, which it isn't, then refer them on. But if you've just got an older child maybe or an adult who's just got difficult to control eczema and they're eating all the food groups, then they really should see a dermatologist to help them manage their eczema, in my opinion. Okay, next case. It is a whistle-stop tour, I'm sorry. So Sarah's a 3-month-old baby born at term but needed IV antibiotics due to aspiration of meconium, and she's formula fed. And therein in itself lies some risk factors for allergy forming. So we know that if you have early onset of antibiotics, if you have a cesarean, if you are formula fed, then that affects the way that the gut microbiota develops. So essentially get more of these bad bacteria than the happy bacteria. And so they are risk factors for allergy forming. The biggest risk factor is still genetics, which was my life, which is why all my kids have got allergies. And it would never be to make someone feel guilty, but it's just an awareness that these are risks that are flagging up to you. And then within 2 months of life, she developed widespread eczema. Her parents tell you she's crying all the time. She's had multiple trips, you can see, to A&E, out of hours, GP, health visitors. She vomits lots and lots of explosive nappies. And this is the history, I can't remember if there's a question or not, but that would be more suggestive of a non-IgE allergy. It doesn't mean it is non-IgE allergy, but it does mean it should be on your radar to think about and rule out, okay? Non-IgE allergy is much harder, I think, than IgE allergy because the timing is much less certain. So, and essentially we're often talking about infants who are feeding all the time, so you can't work out, oh, it's always 2 hours later or 4 hours later, or said to be anywhere up to 72 hours later. But it's about pattern recognition. So these babies have multi-system involvement. So if all they've got is eczema, it is highly unlikely that we're looking at food allergy. You would usually have skin signs and gut signs. So again, NICE have separated it into skin, gut, and respiratory system. So when you look at the skin, they talk about redness, itch, eczema, and often these babies are just quite rashy. So you'll feed them and you'll notice that they seem a bit rashy after feeding. Here is the trickiness with eczema when you're trying to talk to families, because you're saying the eczema itself is not caused by a food allergy. And there's a big Cochrane review showing that. But these children often have very difficult to control eczema. So when you take out the food they're allergic to, often milk or maybe soya, their eczema gets more manageable. Sometimes it does appear to be better, but it will often come back. And then that's when families come back to you and say, well, their eczema's come back. What else are they allergic to? And the point is that eczema was the first thing that developed. And because they had eczema, they're at risk of food allergies developing, but they will still have eczema. And that's really important to try and explain to them when you're seeing them, because everybody thinks their eczema is caused by food, and then you end up with children with really restricted diets. Then I divide it into upper gut and lower gut. So for the upper gut, they get reflux, they're miserable. They're the babies that you don't want in your room, that, you know, I like a baby, I like a cuddle. And then I'm like, oh, God, take it out. My middle daughter was like that. It didn't dawn on me that she had an allergy, but, you know, in hindsight. So ask them, how long do they cry for? If they're like 12, 14 hours a day, you're like, that's not normal. But if it's 3-4 hours a day, like, well, babies do cry. Then you can be a bit patronising. But, you know, not if they're crying for hours and hours and hours and hours. Lower gut, so lots of loose, explosive nappies. It's said that if they're breastfed or mixed feeding, that they might have blood in the stool. But it doesn't seem to happen so much with the formula-fed babies. We don't quite know why. But the breastfed babies get proctitis. And then they get soft stool constipation. So they strain and strain, and when they do go, the stool is soft rather than hard. NICE say there are no respiratory symptoms involved, but actually we do see that these babies are often quite congested and a bit grunty, which is how my own son was. He had a bit of both allergies, just to make life fun. So the commonest ways these babies will present is either like a snotty baby consult, a crying infant consult, issues with vomiting or issues with their bowels, or maybe issues with height and weight. And I just encourage you, when you see a baby with any of those things, or eczema, to just run through the rest. So if you've got a baby with eczema, are they grunty? What are their bowels like? Do they vomit? How long do they cry for? What's their height and weight? And make sure you check their height and weight, because often the height goes before the weight. So check both. Types of milk we can give, so obviously breast milk, gold standard, yes. Also, the thing to know, if you don't know, is breast milk looks very similar to extensively hydrolyzed formula in that the cow's milk that passes across breast milk is very broken down. So most babies that breastfeed wouldn't have an issue, and it might only be that when you give them a bottle of formula or at weaning, that's when the issue comes through. So sometimes they present a bit late. And certainly with IgE allergy, it's very unlikely that we'd need mums to cut things out of their diet, because you'll notice the baby's not reacting to the breast milk. It's usually when they've had the porridge with the milk that they get the hives, not through the breast milk. But that's not to say some babies don't still react. My son was breastfed and he had a non-IgE allergy, so it does still happen. So formulas we can give: extensively hydrolyzed formulas, amino acid formulas, or soya formulas. The extensively hydrolyzed and amino acid formulas are ones that we're going to prescribe. You can buy them at about, I think they're about £60 a tin privately. So, you know, yes, fine if you're a millionaire and you won however much on the Euro Millions, but not most of us. Soya formula, though, I would encourage families to buy if they're going to use it, but we don't recommend it before 6 months of age, because there's a theoretical risk we might feminize our babies because it's got phytoestrogens. So it's not recommended. These are the different types of extensively hydrolyzed formulas. I hope I've included all the names. I'm a bit useless in remembering. Some of them contain whey and some of them contain casein. And some people will argue that the whey ones that have the lactose mean that some babies might still react to it, but the evidence is a bit poor for that. But what I might find is that if I've got a baby that I'm on a whey formula and they're still reacting, sometimes I might try a casein formula first before I then go on to an amino acid formula. So sometimes one will tolerate one and not the other. The other thing just to briefly mention is a reminder about lactose intolerance, which is a completely different thing than milk allergy. And also, please don't call it milk intolerance. It drives me nuts. It's an allergy, so can we call it a non-IgE allergy? But anyway, that's my bugbear. So lactose intolerance is when we don't have enough of the lactase enzyme. In babies, it's incredibly rare in the UK to have that, because you're talking about congenital deficiency of lactase enzyme, and it is very rare in the UK. It happens in Japan and some other areas. We can get a secondary lactose intolerance where for a period of time our lactase enzyme is reduced, and that's often if you've had a gut infection, like they've had a really bad diarrhea bout, and for 6 to 8 weeks they can't tolerate lactose and they get immediate symptoms of explosive stool, tummy cramps, but they can tolerate lactose-free products. People can buy lactose-free formulas, we're not prescribing them. Okay, so just a slight difference for you. Lots of the formulas nowadays have prebiotics, sometimes probiotics, or a bit of both. If you look at the sort of overarching reviews about that, they're still quite sceptical about whether that makes a difference. And a few years ago at the allergy conference, there was one allergist for probiotics and one against, and they had a very big argument about who was right and who was wrong. The challenge with these big meta-analyses is that they only included these like perfect trials of randomized controlled trials that are double-blinded. And the reality is that often these trials are funded by milk companies, and so you've already got bias in. So they're already not going to be the best trials that there are available. But really, I think many of us from practice would say that we do find that there is a benefit. And there's certainly, if you look at the more individual trials, they seem to consistently show that actually children on an extensively hydrolyzed formula versus an amino acid formula with the probiotics do seem to gain tolerance quicker. And frankly, in my mind, therefore, if we ignore the cost of difference, we should be giving something where there might even be a chance that we might gain tolerance sooner. Having lived with a son with a milk allergy till he was 8, I'd have done anything really to have tried to get him to outgrow that sooner, because it really is hard on your life. And then there is some thoughts as well that it reduces the risk that they may go on and get other atopic conditions, so that's quite a big cost improvement potentially, and reduces gut and respiratory infections. So whilst the evidence is a bit, you can see there's some evidence it might help with eczema, I still use them. I think they're beneficial. So common questions that we get asked in primary care. So mum calls one day after you've given a formula and says baby's refusing to take the milk and she wants a different one. What do? What do most people do? They give a different one. Really what we need to do is at the beginning tell them how it's going to be challenging. So babies develop their taste bud by 3 months of age. These formulas taste disgusting, particularly if you've gone from breast milk. It's going to be hard. So 2 ways that I do it. Either if you need them to stay on that formula, then I might give them some vanilla essence, or they buy some, and you put some vanilla essence drops in the formula, and you just slowly with time take the amount of vanilla essence out. That works quite well. Or I titrate across. So if you think a bottle of formula is made up with 5 scoops, I take 1 scoop of the cow's milk formula out, put 1 scoop of the extensively hydrolyzed formula in, and do that for a few days, then take 2 scoops out. And there's no real, it's just a guide as to how to do it. But that is the way that will often work. So babies just need to get used to the taste, essentially. A bit like they do with all food, don't they? But remind families that their stools can become all manner of colours. Green does not mean they're allergic to it. But if you don't tell them that, then of course they don't know. And then they go on these forums and then they get told, oh yes, that's not working, use Neocate. And make sure once you've got them on it, then prescribe them enough. But please don't prescribe 12 tins to begin with, because if the parents aren't using it or whatever, it's a complete waste of money. Now very common. So a week later, she said, baby's not better. What do I do? Please don't prescribe them an amino acid formula. These are from the International Milk Allergy for Primary Care Guidelines. It's about telling people at the beginning that it takes time for these things to work. If you think their gut's really inflamed, if they've been on these milks that are causing an allergy for, I don't know, say 4 months on average maybe, then it's going to take time, just like if you had really bad inflammatory bowel disease or a gut infection for your gut to heal. It will take 2 to 4 weeks. So tell them, yes, some babies are amazing after the first bottle. Most people, it's going to take a couple of weeks. Tell them these things before they waste your time ringing back. These are the indications for amino acid formula. So issues with growth, severe eczema. I would argue that I would probably still try an extensively hydrolyzed formula with probiotics, but it's in the guidelines. Anaphylaxis, yes. If you've been on an extensively hydrolyzed formula for 2 to 4 weeks and things are a bit better but not fully, that might be the time to try an amino acid formula. Or for me, I might try a different extensively hydrolyzed formula, but it depends on how fed up the parent is by that point, really. So the guidelines say go on to an amino acid. Some of these severe gut symptoms, so FPIES and eosinophilic esophagitis, that I do not have time to tell you about. And if you're multiply allergic. So mum says now after a month, baby's much better. Now what do we do? Well, the reality is what most people do is say, brilliant, keep on it. And that's not what we should be doing. I always liken this to celiac disease. We would never diagnose celiac disease and continue to prescribe all these wheat-free, gluten-free products that cost a lot of money on the NHS until we have made them have gluten in their diet, have a blood test, and have an endoscopy. The same applies for most of these babies have not got issues with growth and weight. So you can, play around with it. And again, set your stall at the beginning of the consultation that because a blood test doesn't exist to diagnose it, we have to diagnose it properly. And that means a re-challenge. And I always follow up with, you don't want your baby to have an allergy if they don't have one. It's going to be expensive. You're going to get anxious. They're going to get anxious. It's very stressful. And there is some evidence that if you keep a food out of the diet that they could have tolerated, then you might allow allergy to form. So give them the reasons why they don't want to not do this challenge. And I say, I'm not going to make your baby a screaming horrible mess for weeks and weeks. For me, if you're breastfeeding, I might say, if you're really anxious, why don't you just have a latte and see what happens over the next couple of days and just slowly put your milk back into your diet. Lisa might tell you something different, but that's what I do with my families if they're anxious. If they're formula fed, I do the reverse of what I said. So take 1 scoop of the extensively hydrolyzed formula and put 1 scoop. And how quickly you do that depends on the person in front of you. Some of them want to get on with it. Some of them are going to take a month to take a scoop out. So work with them. But they should re-challenge because the number of times there's nothing wrong with these babies that it was a functional gut disorder or funny 5 minutes or whatever is staggering, really. But the challenge for us in primary care is the dietitians from the hospital don't tell us to do this. The secondary care consultants don't tell us to do this. So it comes back with the hospital, you must put them on this formula, and they never get a re-challenge, which is a disservice to our patients, really. Now I say if you've got a non-IgE allergy, refer to dietitians. Good luck sometimes. There aren't enough of you. Our area, they say, we've trained up the health visitors. I'd love to know how you've trained health visitors to be dietitians. That's amazing to me. So, but anyway, and if they're severe, then refer them on. So this is my little thing. We're nearly there. So cut it out for 2 to 4 weeks. Make sure if they're not at all better, then think about something else. If they're partly better, put them on an amino acid formula. Make sure you do a re-challenge. once you've re-challenged, that's usually the point where we'd recommend a referral, when you've proven your diagnosis. And then finally, so mum says, how long, she's confirmed the diagnosis, how long is she keeping the milk out of her diet for? And the answer is 6 months. So if you've diagnosed at 3-4 months, you might find that the baby might be before the age of 1 when you're starting to introduce milk ladders. From my experience, most babies who actually have a milk allergy, so who did do the re-challenge and everything, probably can't tolerate it till they're about 1. But you can try before. You use the milk ladder. This is the International Milk Allergy. There's recipes that are associated with these things. And going up each rung doesn't induce tolerance. So some babies may well be able to start right at the top and be fine, but really that might make them a really screaming, horrible mess. So we start at the bottom and we work slowly. And it's a bit of a fine art with the person in front of you. So how quickly you move up each rung of the ladder depends on how anxious the person is. So if they're really anxious, you might work with them to move up each rung, every month. And if they're quite good, then you might move up every few weeks. The important thing to tell them is, say they get to step 4 and then they start reacting, don't give up altogether, which is what they do. Stay at the step that you were tolerating and retry again in 3 months. And for anyone that is in primary care, then I would usually say, if, months and months and months are going on and we're not winning with this, that might also be the time, if they haven't seen a dietitian, to ask for some help with that. Or if they have multiple ladders, like milk ladder, soya ladder, wheat ladder, that they're trying to put in, clearly they're going to need help. It is quite complex. Make sure they're well when you start the ladder, so there's no point putting a child with a tummy bug on this ladder, otherwise we're not going to know what we're interpreting. Equally, no point if they're on antibiotics. The challenge is they all start at about the age of 1, and at the age of 1 they all go to nursery, and then they all get sick. So it's hard. It's hard, and yet all GPs are expected to do it. So in summary, advise families of what they have to expect at the beginning, and that will reduce your consultation time. So we're going to do a re-challenge. This is why. It's going to take time for the baby to get better. This is how you're going to get your baby to take this formula. This is what to expect with it. And then they'll be on board with what you're saying, and they won't go and read Facebook. I don't know why I'm saying that, because I'm going to try and get a Facebook group where they come and listen to what I'm going to say. But, most people go and read terrible advice. Give them the tips they need. Tell them it takes time. Please re-challenge and get support where needed, really.